Tunnel syndrome. What do you think?
Like tunnel vision?
No, like carpal tunnel and cubital tunnel, and I'm blanking on the last one right now, but it starts with the tarsal tunnel.
that is what it is.
It is. I
That's
got
not
it.
what it starts with. That's what it is.
I blanked for a second, and then as I was saying that line, it came back. I was like, it starts with the T. The tarsal tunnel. Duh. That was in my brain.
Well, Laura, I have a lot of thoughts on tunnels.
Not the one that the trains go under, right?
I mean, that one too, but that's not what I'm talking about today.
Okay. Well, let's go ahead and choo-choo our way into it.
The wrong train. Wrong tunnel.
The PTA Podcast with your hosts, Ken
and Laura. Thanks again for joining for another exciting episode. All right. So let's go ahead and talk about tunnel syndromes.
So am I going to my story first?
Sure.
So this is actually going to be related to two other episodes we've done. One was 6 months after the field, and two actually are posture and ergonomics.
Ooh. I can see how they relate.
Yeah. So when I was a tech, I started being a tech at a high volume clinic. And after 3 years, more or less, I was trying to decide if I should go to PT school or PTA school. And I was talking to some of the PTAs about the pros and cons and whatnot. And they all love what they did. But one thing coming from my clinic was this hand pain. And we've had therapists there that were treating for 3, 5, 7 years. And so I was kind of wondering like why that could be, and it was just the amount of volume that we treated. It was the amount of soft tissue that was done and the toll that it was taking on their hands.
I could see how that definitely came into play.
So I was kind of thinking, all right, well, if I committed to the PTA route, how could I avoid being in that same situation? Whether it's you kind of using different techniques, doing more MOBs, maybe doing more tool-assisted STM. Maybe that's the answer. And I went to PTA school. I committed to that. And here I was, found myself in the same clinic as a PTA. And the reason why I bring up the 6 months after podcast episode was because after 6 months of being in the field as a PTA in that same clinic, I found myself in that same spot. My hands were hurting. They were just constantly sore. And I kind of thought to myself, like, where am I going to be in 5 years? Like, is this kind of my route? Because we're such a hands-on field, we're prone to getting carpal tunnel syndrome. We're documenting all the time, so we're on our computers. That's why I bring up the whole ergonomics thing. And I didn't want to be in that same boat where 5-10 years down the road, I can't practice anymore because of the pain in my wrists.
It's interesting that you kind of bring that up, because if you look at our field too, like, you don't really see elderly people practicing in our field.
Yeah, one, it's hard to find them, and two, if they are, it's definitely not in outpatient orthopedics.
Yeah, rarely.
Like, I found some, I'm saying I found some like they're a rare commodity, but I've met them in the wild. I've met a few older treating therapists, but most of them are acute, either doing wound care or asking for a lot of assistance from other therapists. Whether they're a mod assist or a max assist, they were almost never able to do it on their own. They always had to get some help. So it kind of comes and goes, kind of depending on what field you're in. If you're in acute and you're doing these assists, you're looking at back pain. If you're an outpatient doing a lot of manual work, you're looking at hand pain.
Oh, yeah.
So
I could see that.
Bringing in that's why we kind of segue into our discussion today, talking about just tunnel syndrome in general. Mm-hmm. We bring up carpal tunnel syndrome because, one, it's the most prone to our field, and two, it's just the most common in general.
Yeah. Like, I Googled, just out of curiosity, top tunnel syndromes, and carpal tunnel by far came up as
Yeah, it's
number
not
one.
even close.
It's not even close. Like you hear about the other ones, and I think that's the thing is like I definitely can think of how many times I treated carpal tunnel syndrome, but like the rest of them, like I would have to have a refresher on what actually needs to be done for those, just because of the fact that they are so rare, that they're not very common.
For carpal tunnel?
No,
for the other ones.
for the other ones.
Yeah.
So like I'm like carpal tunnel, I feel like I could start right off the bat and like I know what to do, but I don't know all the other ones.
So the other two main ones are cubital tunnel syndrome, which is more ulnar nerve involvement going from the elbow, and the last one is tarsal tunnel syndrome, which is more the nerves in your foot.
Yeah.
Causes, it's all over the place. That's why I didn't really know if we were going to get into that, because it can be anything from water retention to just a narrowing of the canal to pregnancy to bone spurs to fractures. Like there's so many causes
factors
that I didn't really think we would get into.
But like the big thing, like we talk about, is it's the fact that nerve is being compressed around now.
Correct.
That's the big thing. It's kind of like, I think it's like almost like DDD in a way. Like cubital's kind of the same. I mean, tunnel syndrome is kind of the same thing, where it's being compressed on, and so like there's so many factors that could be involved with it. But whenever I hear tunnel syndromes, any type of tunnel syndrome, I automatically already know the nerve is what's being compressed and aggravated here. So
so I actually, and just for carpal tunnel, because I couldn't find it for the other ones, I have the clinical practice guidelines to treat carpal tunnel syndrome. If you don't know what a clinical practice guideline is, it is a giant sheet that talks about the effectiveness of treatments. So it kind of goes into a star rating. So having 4 stars is really strong evidence, and then it goes to 3, 2, and 1. And a lot of what people mention nowadays is practicing with evidence-based practice. So we can leave a link in the description, because 1, it's very long, and 2, I might fall asleep reading it.
Well, we'll probably throw it up on Instagram, honestly. It's like the best place to put links. We'll add something there.
But it's something,
or check out the Discord too.
Yeah, we can leave it on Discord. So it's kind of something just to kind of look at, knowing what things are effective. Like surgery, for example, very effective. Steroid injections, very effective. Oral treatments, not as effective. And
I would think that would be like oral steroids too.
Like steroids is an option. That is the same as oral treatments.
Yeah, that's what I'm saying.
There's two. Those are 2 categories.
Oral treatments and
oral treatments, and then the next one is oral steroids. They both have the same star rating.
So maybe oral treatments are just using like anti-inflammatories like ibuprofen?
Perhaps.
Maybe.
But it's moderate evidence for both of them, either way. But this is kind of just in the know for you to be aware of what's going on with carpal tunnel syndrome.
Yeah, I feel like it's interesting because, carpal tunnel syndrome can be treated with or without surgery. I feel like more days we are starting to see the conservative approach, which is great, I think.
There are, I'm going to mention, I only really looked into one research article, but there were topics on how effective conservative was versus surgical.
Yeah.
I'm not surprised. It just depends.
It depends on the person.
It depends on the person, the cause. How that's the
what
hard
job
part.
they're doing, because the thing is, like for example,
what do they do for their living?
If you are repetitive, again, a lot of times we see it in repetitive positions. I should say it's more positioning than movement.
I mean, I would say actions too.
I guess both. Yeah.
Like for us, is soft tissue. Like a lot of massage, like we're not in just one position.
Yeah, but I think it's more of like because of the like where we put our hands and that kind of stuff. Like I don't know. It could be both, honestly. Like we talked about, there's so many different.
There's a lot of causes.
And so like if you're going back to a job that's just going to be doing the same thing over and over again and putting you in that position, I guess the reason I think positioning is because one of the things that they give you is a brace to prevent you from.
Yeah, because you get some splints.
Yeah, you get some splints.
Braces and splints.
So, like if you're going back into that position without adjusting anything or making everything a little bit, again, more ergonomic friendly, then you're going to continue to have the repeat of just causing aggravation to that area. And sometimes you wait so long that even if you're just doing physical therapy and steroids, like no matter how conservative you try to be with the treatment, it's just not going to work because it's
I feel like
so
that's
much
like a
damage has
rule
been
of
done.
thumb for everything.
Oh, I agree.
Like if you have a lot of knee pain, but you do a lot of walking, we're going to fix your knee pain, but then you might go back to the walking and it might hurt again. Like you have to get to the cause.
Yeah.
Same with, like carpal
I
tunnel. Like
agree
if
with
you don't get to the
that.
cause, you go back to whatever you're doing, it's going to come right back.
Well, yeah, and it's the same thing as if you've done already so much damage, like you can't undo the damage. Like you
Yeah,
might
and depending on the
just have to.
severity.
Yeah, no, I get what you're
There's
saying.
a lot
I
of
totally agree with
activity modification and then kind of changing it from there.
that. I just feel like maybe definitely with thinking of carpal tunnel, it's just so easy
To happen again.
for it to recur. Like for example, like you think of like we're going to be doing this topic in I think upcoming weeks. I don't think it's next week or the following week, something like that. But we're going to do thoracic outlet syndrome. For like example, with that one, like it's a lot has to do with sometimes positional and that kind of stuff too, right? But like I feel like
that one's the same thing. Like,
but I feel like that one you can get rid of it and it takes almost years to come back. Most of the time, like at least my personal experience from it, where like carpal tunnel, literally like patients will have relief for like a month and then they're back in. Like it comes back so quickly, I feel like. And I think it's just because of how small the area is too, if that makes sense.
I just feel like it's just the cause. Like it's just so hard.
Yeah.
Because there's so many different, like even thoracic outlet syndrome, I know we're going to get more into it, but like just there's also so many causes for that.
Oh, yeah.
Like if someone has numbness in their hand, right?
Mm-hmm.
And one thought immediately is carpal tunnel syndrome. But you have to almost think about, okay, well, is it going up the arm? Is it cubital tunnel syndrome and they're feeling it in the hand? Is it a thoracic outlet syndrome and they're feeling it in the hand? Or is it starting in their neck?
Cool
and
tests.
it's going to their hand. So yeah, so you have
That's why it's important
your
to test,
Fehling's
too.
test and
To understand
Tunnel
those
sign
special
to
tests.
know whether or not.
And I'll be bad. I'm
It is carpal tunnel.
not bad. I'm not great at knowing tests because we briefly discussed them in school. If that, honestly, my ortho was not the greatest in the school. But
Do you have
I'll look it up.
a patient experience treating someone with carpal tunnel?
More than one.
Anything like that stands out to you while you're treating them?
Well, I remember, so we had a patient who came in for post-op carpal tunnel. Overall, he was progressing really well. However, we got to stand still when it came to more oh gosh, see, I can't talk. Dexterity movements.
Gotcha.
So like, buttoning up. He was a dealer, like pushing the cards out so like he can deal them out correctly. He was having a lot of those issues going on, and it kind of came to a standpoint where we kind of felt like we reached the best we could and that he needed a little bit more specialty niche, and we recommended him to OT. But he did not grasp why we were recommending him to OT, and he just kept telling us to fix it. And we're like, look, this is more fine motor skills that we don't we're not a hand specialist there clinic. We don't get that many of these, and most of the ones we do are just kind of straightforward cases, and they're pretty young and they bounce back pretty well, and you're just not. And
so kind of bringing up OT, not so much like a week because everybody's so different, but is there a certain milestone that you have in your head that once they reach that, they should be sent off to OT for that more
personally,
ADLs kind of training and rehab?
Yeah, personally for me, this is where it just kind of bugs me about our field, is I think someone who is dealing with definitely the hand in an outpatient setting, even sometimes inpatient because of how much they use OT, I feel like they could go to OT. They shouldn't be recommended to PT.
So not even at all. So if
Yeah.
someone has carpal tunnel, just send them straight to OT. Don't even
Because
send them to PT.
they're gonna look for those fine motor skills better than I am. At least mine. Like I've never worked that much with hands, so like my skill set in general is just not that well. Like
It's its own specialty.
Yeah.
You
So
can
like
be a literal hand specialist.
yeah, and so like I feel like I'd rather you go there than come to me because I'm not great with it.
So
I'll do my best.
You're not downplaying yourself. You're just recognizing those with those certain certifications and
That
skill
they're
set.
special. Like yeah, exactly. I'll do my best up until the point I can't. I think it just depends on where you feel like your knowledge goes in a way. Like so for me, it wouldn't be a specific milestone. It's just to the point where like you're not progressing, and I'm stumped on what to do. That's pretty much like where I'm at. Like that's when I would probably refer out. Like I don't think I'd give you a specific one if that makes sense.
I think I've only probably treated one person with carpal tunnel. I've worked with quite a few when I was a technician, but
I felt like we had a lot.
myself treating, I think I've only treated like one.
We had a lot early on in our days. I feel like
We did.
That hand station was always being used.
And like you said, like a lot of those activities, we can regain most of their gross motor functions, like just moving their hand and do some,
Yeah, and I think
tendon glides and
I look back at the ones we
whatnot.
had definitely early on, and most of those were not. They were choosing non-operative. Like they were pretty early onset. Like within the like it happening, they weren't post-op at all. Like so, like I think maybe like if they were non-post-op ones coming in, I would definitely feel more comfortable with. But post-op, maybe going to a hand specialist just because of the fact that things get kind of a little wonky after surgery.
Yeah, so I think the one that we had was he worked as, I don't even know what, like metal crafts, but very tiny metal crafts. So working with like tiny hammers and the little needle that melts metal so they can, I don't even know what it's called.
I'm blanking. I know.
Do you know what I'm talking about?
Yes, I know exactly. Like a little welding tool.
Yeah, it's more, not...
It's like a little... It's a welding tool.
Yeah, it's like a little welding tool.
It's a welding tool, but it's
pen-looking
like
thing.
it's almost like the people who like work on watches, like those tiny little
Kind
things.
of.
Yeah.
Yeah, so he would make little things and he would teach courses as well. So much time working in this fine motor skills, he developed carpal tunnel, and he got a bilateral release. Mm-hmm. Which, one, I was actually kind of surprised because he can't use either of his hands really to do any of his stuff. But they were just like, we're just going to put you under and just take care of it at one time. And I think we saw him for like maybe 1 or 2 weeks, and then we sent him off to a hand specialist. Because again, like that's
We got into
its
more of that
own
fine
thing where it's,
yeah.
But no, we didn't even reach that.
Oh.
We didn't even reach the point where it's like, hey, we've done as much as we could. Like, we treated him for a little bit. He went to go see his doctor, and his doctor was like, all right, we're going to
Switch you over
to a hand specialist.
Yeah.
And it's not like we weren't trying. It's just like,
It's just limited.
we couldn't even be mad. We couldn't do much.
That's where, like, I feel like it kind of wraps back into our conversation of, like, should physical therapy start going into more, like, or do we think that physical therapy is going to go into more, like, specialty, kind of like what doctors do, where you have a general and then you have, like, specialty of, like, women's health, men's health, hands, like, lower extremities, prosthetics, like, so many, like, do we think that'll divide that way? And this is where I could see more of the benefit of it staying within our field, us doing it, but patients getting the best outcome possible in a way. Because it's not like...
I don't think OTs are ever going to let us take hands away from them.
Oh, no, I just was my saying. But, like, if you have carpal tunnel, like, you can have someone, you can have a... This is where the OT and PT debate comes into play of, like, when you work inpatient sometimes, and I'm not saying all, but, like, when I worked inpatient, the OTs and CODAs there believed anything shoulders and up, all them. Anything below that, all us. Except for, like, neck and back. Like, we got...
Oh, yeah, that was definitely the inpatient setting.
Yeah, and so like it's not that our goal is just not so much the fine motor skills, but the gross motor skills. So like, when we're working on walking, we're working on those larger muscles, getting the whole gait pattern down and everything like that, where they're working on making sure that you can put your pants on while balancing or something like that. You know what I'm saying? Like, so like it's just, I feel like you can't just say hands or OT or whatever like that. Like there is going to be, again, like we kind of talked in our Friday episode, a little bit of like fading
Crossover.
in, crossing over, fading in, fading out. Like, but like when it comes to those fine motor details, like definitely post op, I think OTs should just take them. I think hand specialists with OTs, and OTs have more hand specialists.
Oh yeah, without a doubt.
Just take them.
PTs can do it too, but that's not very common.
But I think like if you're there like pre-op where everything's still like intact nicely and we kind of know exactly what's going on and there's nothing else, like it's in a way straightforward, like I think PT can take them at that point in time too. Definitely if you don't know if it's like thoracic outlet syndrome, if it's cubital tunnel syndrome, or if it's carpal tunnel, like if it's still kind of just in that region, like it's a great time, like it's great for us to take on because then we can narrow it down.
And I mean, we kind of touched on the other tunnels, mainly just because they present similarly, they get treated similarly. Surgery is available to all of those as well. They'll do the same thing. They'll just do a release, or you just kind of treat conservatively. But we kind of just wanted to group tunnels syndromes as a whole, with carpal tunnel being the most common and most prone to our field itself. Thus my fear and worry, because I don't want to go through that. I did have a research article, which can be tied into our KT taping episode.
Ooh.
So,
should we do more taping, guys? Let us know.
Do what?
I said, should we do more taping? Let us know.
Oh, should we do more taping?
Yeah.
Like you and me personally, or should our field do more taping?
Both. I didn't think about it that way, but both.
I didn't know how you meant it.
No, I didn't. That was great.
So the article that I have, they took mild to moderate CTS workers that do manual labor, and what they did was they put KT tape on their flexors and put sham tape on the other ones.
Okay.
So it was a double blind. No one knew whether it was sham or real.
I love a good double blind study.
And their conclusion was that KT tape was an effective and safe alternative to surgery. So these patients, the control group, said that they had less pain, they were able to do more of their activities. They judged it off a score. I forgot. Let me hold on. I have it up right now. Let me scroll up. They used a Boston Carpal Tunnel Questionnaire scores. They did a pinch and grip test and an electrophysiological examination of the median nerve. So they got a couple little variety there. It wasn't just like a
things that we actually, I feel like we use in the clinic, though.
Like it wasn't just like a, how's your pain from 0 to 10?
Yeah, but I feel like that's stuff that is actually
relevant
to the field because it's what we do.
So they did all those and they found that it was effective. A couple things that I want to bring up though. One is that they only had 30 people. So it was
tiny,
very rather small control group.
Sounds like my test.
And two was what they did for exercises. It didn't really mention what they did at home, what they did in the clinic. They just put this KT tape on, and then I said, go back to work.
I would like to know if like they all did the same or any of that kind of stuff. If their programs are the same.
And then the plot twist, which kind of confused me a little bit, was that the sham group also said that they had less pain. It was statistically different.
Placebo.
That's why they said that the KT tape was effective. But
because there was still like it was an improvement from nothing to the KT tape was significantly greater, and then it was still significantly greater than the sham tape that showed just an improvement from 0.
Yeah, so statistically they could say it worked.
Yeah,
but the sham group also had less pain. So they didn't know if it was like more of a... They
The
had
question
more
is if they're
confidence
doing
wearing it in.
physical therapy too, though. Then that could be the reason too. That'd be
True.
interesting if they are doing physical therapy at the same time, or if it was just tape.
But yeah, I thought that was interesting.
That is interesting.
Whether or not you believe in taping, we have an episode with our thoughts on it. So
great debate
the
that
great
will
debate
go on
debacle
for years,
of the taping.
decades. But yeah, no, I found an interesting one. It's not so much has to do with actually like carpal tunnel syndrome or any tunnel syndrome. With relative,
has nothing to do with tunnel syndrome.
Well,
do you know what episode we're on, Laura?
in relative of like physical therapy in the world, but I thought this was just fascinating, so I kind of wanted to share it. It was saying that carpal tunnel syndrome actually could be a potential early/red flag sign for amyloidosis.
What?
AMYLOIDOSIS.
Okay.
Say it.
I have to look at it. You tell me the letters is not really sticking. Amyloidosis.
Yeah, that's what I just said.
Okay.
Amyloidosis. Close enough.
All
But
right, Laura, what is amyloidosis?
so it is actually an autoimmune disease that attacks oh my gosh, sorry, like the soft tissue throughout your system. So like it affects your heart, it affects your organs, like there's a bunch of just things that, and it breaks, like it literally is like your body breaks down. Anyway, it affects one of the oh my gosh, I'm blanking on the word right now. And I can't find the word within my article. But it affects, like, I think one of the proteins, if I remember correctly. But pretty much, it's severe. Prognosis is not very good once you get diagnosed with it because it's quiet. You don't really know you have it until it's too late. But they found that when biopsying patients who had carpal tunnel while in there and they biopsied it, they found that they could find the link to this autoimmune disease and that they could get ahead of the game versus being behind of the game. So now they're thinking that people who have who have carpal tunnel possibly could be a red flag for this disease. Definitely, if there's other things going on
So
too.
I'm curious with that research out. They're testing for it when someone has carpal tunnel.
It looks like now, yeah.
I mean, I would hope so.
Yeah.
Like if it's showing signs that they could be related and one is significantly more severe than the other, I would hope they would start at least screening for it, which in a couple weeks we're going to be talking about my in-service topic, which is also going to be more of an awareness thing, because that sounds like an awareness thing. Just be aware that this could be a sign of that.
Yeah, and it's definitely like it starts with, from what I read of the article, like it starts with carpal tunnel syndrome and then it progresses to cardiac issues. But that's the thing is like if they are having surgery because it's so significant, they're now testing for it so that way they know kind of the root cause, and then of course they can dive deeper in and get proper treatment before it's too late in a way. Which again just kind of goes back to with the fact that carpal tunnel, there could be so many different reasons of why it's going on.
We didn't even touch on just thought diabetes can be one too.
Yeah, there's
I keep thinking of more and more
causes. There's so many different ones, and that's where, like, for us, it's not our job to really assume how they're getting it so much. It's to treat the best way as possible. Like, we can help with, decreasing those symptoms and things we do know for sure that they can change and that kind of stuff. But, like, by all means, don't start going to the patient and be like, oh, you might have this, da-da-da-da-da. That's, by the way, that's really bad. And scare them after that. Don't do that, please.
There's a disclaimer. Laura's disclaimer there.
It was I'm for the one person. I'm not saying I think our audience is smart, so I don't think we need that disclaimer, but
she's throwing it out there anyways. Before you start saying everybody's got amyloidosis.
Right? If
I don't even know if I'm saying it right.
Right? I was like, if you can say it correctly.
That's how I'm saying it, because that's what it looks like, but
I thought that was
saying it right.
That was some of the new research that I had found that I thought was interesting, just to kind of go along with carpal tunnel. That's why I was like, it wasn't really truly for our field, but it was something interesting. So
to wrap up the episode, going back to my story on how I outlooked my next 5 years, I decided to leave the practice that I was at and join a different practice where the volume is not where I'm at now, where the volume is not as high. Yeah. So I would recommend, if anybody else has those concerns as well, trying to join either switch the field every once in a while or go to some sort of specialty where you don't put yourself in that position. Yeah. And just kind of stay active. Because, again, kind of like how I said, if you're in inpatient, you still have your cons and your worries there. If you're in a SNF or an LTAC outpatient, there's always going to be something, because what we do is very repetitive. Mm-hmm. So as long as we stay healthy, stay active, stay moving, do what we learned to do for ourselves.
Yeah.
Because as much as we treat the patients, we should be looking out for ourselves as well.
It's like the oxygen mask thing when you're on an airplane. You got to put it on yourself first before you can put it on someone else.
Yep, just like that.
But I'm with you on that. Like, I will say one thing is, remember, like, our field, like, when we bring out these points, it's not just our field that's always going to have issues or potential things down the line. That's every field out there. This is just something that we have been taught and told and have experienced ourselves. And so, like, I don't want people to think, definitely if you're like a student or something like that, like, don't get down on the field because you're like, I don't want to get old and have all these issues down the line. It's like, no, now we're aware of these. Like, let's
address them early.
Let's address them early and see what we can do on early. So that's more of like, does that make sense?
Yes.
That makes sense. Yeah. So that's something just to think about. But I think that wraps it up for today. You got anything else to add?
Nope, that was it.
Well, we appreciate you all like always, and we are so excited to watch the podcast grow. Also, the YouTube channel, it's been amazing. I hope you guys are enjoying some of the new content coming out. Let us know by liking or disliking or whatever.
It's a learning process.
It is.
It's been brutal watching sometimes. It's like, man, we mess up so much, but
yeah. Oh gosh, I can't listen to myself back.
The best thing we can do is just put it out there and just get started.
Yeah, and we just want to have some. Again, this is just to bring the community together, bring up some interesting points, talk about some things that you might be feeling but too nervous to bring up with others.
And if you disagree with us, just let us know.
Yeah, we're all for this. This is a full-on conversation. Sometimes heated debate.
Sometimes.
But don't forget to check us out on our Instagram, where we are the most active. You can find us at _PT_assistants. We are also active on the PTA social Discord app. Is it an app or it's just Discord?
It's both. You can go online or on the app.
Okay, yeah. We have, Nick was nice enough to give us our own little area where we can post content and discussions and ask you guys some questions. Again, we can talk all day about topics we like, but we really want your guys' feedback. So don't forget to let us know what you guys would like to hear about.
I'm not gonna lie, that was quite the lengthy outro, but I like it.
It was a lot.
We'll catch you guys in the next one.
Bye.
The information in this video or podcast is not intended nor implied to be a substitute for professional medical advice, diagnosis, or treatment. All content, including text, graphics, images, and information contained in this video or podcast, is for general information purposes only and does not replace your professors or a consultation from your own doctor or healthcare professional.